Pleasure to present Professor Evgenya Patrakeeva, consultant endocrinologist at the first St. Petersburg Medical University, especially interested in insulin treatment, patient education, and her presentation is entitled Diabetic Neuropathy, Different Treatment Modalities. Please.
Dear colleagues, dear friends, it's a great pleasure for me to be here in this beautiful country full of history and culture. I work in St. Petersburg, which is also a very beautiful city, as you can see here. But my city is like a baby in terms of age compared to Cairo, of course. And before we start to discuss diabetic neuropathy with different treatment modalities, I want to suggest two organizational issues. First one, don't waste your time making picture, because if you need something, some slides, presentations, pictures, guidelines, you can just write me by email, and address is written here. So don't be hesitate or shy, just write me, I will send you everything, whatever you want. And the second issue is about the time. We are a little bit out of our timetable, so I just want to ask you, please ask your questions during the break, or during the lunch, or during the workshop, not after the lecture. Is it okay for you? Yes? Thank you for understanding. So let's start from some main thoughts about early recognition and appropriate management of diabetic neuropathy, which is matter. First is a diagnosis of exclusion. Second, up to 50% of our patients with diabetic neuropathy may be asymptomatic, and it's very important. Third, numerous treatment options exist for symptomatic diabetic neuropathy. And the last one, recognition and treatment of autonomic neuropathy may improve symptom, reduce sequelae, and improve quality of life for our patients. As an introduction, we have some important facts about neuropathy. Of course, the presence of this complication, even with trivial trauma, is an initiation factor for the development of foot ulceration. The risk for diabetic foot ulceration increases by 7-fold in patients with neuropathy. From 45 to 60% of all ulceration in patients with diabetes are mainly due to neuropathy. And the last one, almost half of the ulcers are due to combined neuropathic and ischemic factors. That's why we need to remember that diabetic neuropathies are the most prevalent chronic complication of diabetes, and it's not only the one condition, it's a group of conditions. Because of that, we need to remember that there are a classification with a lot of forms of neuropathy, with diffuse neuropathy, mononeuropathy, and even radiculopathy, of course, which is atypical. But also we need to remember that there are a lot of comorbidities which we need to differentiate from neuropathy. It's metabolic disease, systemic disease, infectious, hereditary, industrial agents, inflammatory disease, and some nutritional things. That's why just come back to our main thoughts, which was written in the first slide. Diabetic neuropathy is a diagnosis of exclusion. Of course, non-diabetic neuropathies are common in diabetes. That's why non-diabetic neuropathies may be present in patients with diabetes and may be treatable, and we need to remember about it. There are some common facts about pathogenesis which we need to remember. Everything starts with hyperglycemia, with some changes, which leads to nerve dysfunction and death of cells. From the other point of view, if you want to compare situation with type 1 diabetes and type 2 diabetes, or even both of types, there are some differences between, but the consequences is following. We have DNA damage, ER stress, mitochondrial dysfunction, cellular injury, and irreversible damage. Why is necessary to remember? Because of this complicated pathogenesis, we have a lot of signs and symptoms, even negative or positive with some spontaneous sensation or pain, or even evoked pain. Also, we need to remember that symptoms don't match signs of nerve damage, and it's very important. Neuropathic pain, it's not an easy condition and occurs in even 30% of patients. We can divide it to small fiber neuropathic pain, large fiber neuropathic pain, and it occurs in patients with long-standing poor diabetes control and increased variability of blood glucose level. Of course, we have a lot of things to diagnose neuropathy, and everybody knows it. And also we need to remember about some possibilities to measure function, pressure, and balance. And also we need to remember about the role of neuropathy in diabetic foot ulcer pathogenesis, as you can see here. If you can imagine the way to the diabetic foot ulcer as a final destination, of course, the first station will be neuropathy. After that, maybe ischemia, loss of protective sensation, and high pressure points. If we will again describe the best way to amputation diabetes in some allegorical way, first stage will be normal foot with absence of neuropathy, and the stage 2 will be high risk of foot, presence of neuropathy. Let's go to cornerstones for prevention of amputation in diabetes, because it's matter. It's periodic foot examination, of course, education not only the patients but healthcare providers, appropriate footwear, treatment of pre-ulcerative conditions, and early treatment of foot ulcers. That's why it's important to remember that if diabetic peripheral neuropathy is not recognized and if preventable foot care is not implemented, patients are at high risk for injuries to their insensate foot. That's why we need multidisciplinary foot care service, which need to include diabetology, nutritionists, podiatry, vascular surgery, microbiology, and some other specialists, and even nurses who are specialized in diabetes. Is amputation really preventable? How do you think? Let's raise your hand who think if yes, it's preventable. Who think that it's not preventable? Do we have some doctors? No? Great, because really at least half of all diabetes-related amputation can be prevented by adhering to the good foot care and multidisciplinary approach, and it's very important. So what do we need to do for screening and diagnosis? All patients with type 1 and type 2 need to be screened. We need to screen even patients with pre-diabetes. We need to have a careful history examinations and all procedures which we'll describe before. But we need to remember that electrophysiological testing or referral to neurologists is rarely needed. So we can do almost everything by ourselves. Let's start to talk about management of symptomatic diabetic neuropathy and some treatment modalities. Of course, again, we need to exclude non-diabetic causes, including malignant, toxic, iatrogenic. We need to assess level and stability of glycemic control, and we need to explain, support, and educate our patients. If we will divide all treatment modalities to some ways, first of this way is disease-modifying treatment with stable near-normal glycemia and maybe alpha-lipoic acid. And the second part is symptom-modifying drugs, which could be medical and physical. Of course, there are numerous treatment options exist for symptomatic diabetic neuropathy. You need to remember about it. What do we think about when I'm talking about symptom-modifying treatment? We have antidepressants, anticonvulsants, with some group of medications here and here, and also some other modalities like opioids, others, local treatment, and non-pharmacological treatment at all. If we will discuss some groups, because it's like a very practical question, and yesterday and tomorrow morning you asked me to be more practical, so I'm trying to do with practical issues. We need to remember not about the only about mode of action, cautions, but also about side effects. And you need to remember about sedation in terms of DCA. You need to remember about some problems with nausea when you're working with SNRI, about sedation with gabapentin, something else with pregabalin, and some problems with abuse in terms of opioids. What is the other important question? It's a question about dosage, and the dosage can be different from the initiation and during the treatment. You can see it here when we're talking about the first group of drugs, or here. If you're talking about antidepressants, you also need to remember about the dosage, or even in terms of opioids. So, what is the main consideration about pain management? First, we need to consider either pregabalin or duloxetine as the initial approach in the symptomatic treatment. Second, gabapentin may also be used as an effective initial approach. Tricyclic antidepressants are also effective, but we have a high risk of serious side effects. And of course, given the high risk of addiction and other complications, the use of opioid is not recommended as a first or second-line agent. That's why we need to remember that, of course, there are a lot of treatment options, but we need to be careful with usage of all these treatment modalities. If you will summarize the process of management, here, tight glucose control in patients with type 1 diabetes dramatically reduced the incidence of distal symmetric polyneuropathy. In patients with type 1 diabetes, with more advanced disease and multiple risk factors and comorbidities, intensive glucose control alone is modestly effective in preventing distal polyneuropathy, and patient-centered goals should be targeted. Lifestyle intervention are recommended for distal symmetric polyneuropathy prevention in patients with prediabetes, metabolic syndrome, and type 2 diabetes. And of course, a lot of treatment options we have now. Some word about diabetic autonomic neuropathy. It's a chronic complications. Among the least recognized and understood complication of diabetes, despite its significant. And of course, it's have a good damage for our patient. Is it recognizable? Yes. Is it common? Yes. We have some problems still in screening and diagnosis, but we need to keep in mind that symptoms and signs should be assessed in patients with microvascular and neuropathic complications. In the presence of symptoms of cardiovascular autonomic neuropathy, tests excluding other comorbidities or drug effects also, interactions maybe that could mimic cardiovascular autonomic neuropathy should be performed, and it's very important. Of course, physiological function of both the sympathetic and parasympathetic nervous system is huge. That's why we have a lot of symptoms and signs from the cardiovascular system, gastrointestinal system, urogenital system, even from pseudomotor system. Let's start from cardiac signs and systems. And of course, I need to remind you that CAN is a significant cause of morbidity and mortality associated with a high risk of cardiac arrhythmias and sudden death for our patients. And they have a lot of clinical manifestation of this complication. It's possible to divide it to some stage, early stage with possible early complication, definitely confirmed complications, severe advanced and symptomatic. But the very important issue is that we have diagnostic algorithm for this complication, for resting tachycardia, even for hypotension. If we will talk about gastrointestinal complication, let's divide it to all gastrointestinal complication of diabetes or gastroparesis. Of course, with a lot of signs and symptoms again. We also have some problems with other system, with erectile dysfunction, which huge prevalence, and neuropathy is one of the leading causes of this complication, And also, we need to keep in mind that it's a predictor of cardiovascular events for patients with diabetes. From the point of view from bladder dysfunction, of course, diabetes duration matters. We have a prevalence, and it's very high. And diagnosis should be made by using a validated questionnaire. Pseudomotor dysfunction, it's also important for our patients, and it may result in dryness of foot skin. It also can be a risk factor for diabetic foot ulceration. We need to detect this complication, and we have a quantitative pseudomotor axon reflex test for diagnosis, and some other available techniques. How should we treat this complication? Of course, it differs for each form of this autonomic neuropathy. So we have some treatment for cardiovascular system, for gastrointestinal system, genitourinary system, metabolic. Of course, we need to remember about optimal glycemic control, and even for pseudomotor system. And again, we need to remember the main thought. Recognition and treatment of autonomic neuropathy may improve symptoms, reduce sequelae, and improve quality of life. And it's very important for all our patients with diabetes. To conclude this part, I want to say that DAN is a particular aspect of diabetic neuropathy which leads to multisystemic impairment in both type 1 and type 2 patients. Cardiac system is the most seriously involved. As nowadays no therapy is able to effectively reverse this process, prevention with strict glycemic control, multifactorial intervention, and lifestyle modification remains essential. And again, I want to remind you our main thoughts, our take-home messages for you. The first one is that diabetic neuropathy is a diagnosis of exclusion. Second, up to 50% of diabetic peripheral neuropathy may be asymptomatic. And if not recognized and if preventive foot care is not implemented, patients are at high risk for injuries to their insensate feet. Numerous treatment options exist for symptomatic diabetic neuropathy, and recognition and treatment of autonomic neuropathy may improve symptoms, reduce sequelae, and improve quality of life. Thank you very much for your attention. I hope for a huge amount of your questions during the breaks, during the lunch, during the workshop. And please don't be shy and write me if you need any slides or something. If you use social media, I kindly ask you to follow the official account of EASD. It's EASD News. And if you want to spare your opinion or some comments, if you have some pictures, you just can do it with hashtag EASD Postgraduate Egypt, which is written here. So we will be happy to know your opinion about everything which has happened here. Thank you very much.
Thank you very much, Spasiba. As you heard, we're going to take discussion later on this workshops, or you can interact, and she's not difficult to spot in a red dress there, so you can find her easily. Again, it's